Good evening and welcome to our program, presented by Tampa General Hospital. Please welcome to the stage TGH President and CEO, John Kouros.
Good evening, everyone. Thank you very much for being here tonight. My hope is that this will be a rewarding and enriching experience because the opioid crisis and mental health issues in our community and across the country, addiction in general, is really a very big issue for all of us. We're hosting this important forum tonight in honor of National Patient Safety Week. And I want to take a moment to recognize if there are elected officials in the room, if you could stand for a moment and be recognized. Thank you for your leadership and thank you for being here tonight with us. I also want to take an opportunity, and I know I have a lot of Board of Trustees here with us, our trustees with us, and if you're in the audience, and I think you're over there to my right, if you could stand for a moment and be recognized, just for a second. You're a humble group of people. You're a very humble group of people. The Board of Trustees is led by John Touchton, our chairman, and Phil Dingle, our vice chairman. Thank you all for being here tonight. I say this often, but if it was not for our trustees and their unwavering support of this institution and this community, Tampa General Hospital would not be the institution it is today. So thank you for your service and all of your support and leadership. I'm driving over tonight, and one thing that drives my staff crazy a little bit is I don't really follow the script, what they put in front of me. I try my best, but I oftentimes don't do it. They're getting used to it, actually. After 2.5 years, they're starting to get used to it. But I was thinking about tonight, and before I give you my prepared remarks, I wanted to actually share a story, a personal story, actually, about addiction. Prior to coming to Tampa, I lived over on the east coast of Florida, in South Florida, in an area called Jupiter. It was Palm Beach area. I had a very good friend, and not only were they good friends of ours as a family, but our boys were friends. And they went to a private school together over in Palm Beach. And basically, this family could really generally afford whatever they needed to for anything, quite frankly, health, mental health, anything that they needed. And they had a young man who was quietly suffering from mental health issues. Not a lot of us knew it, actually, but he was. He was a 16-year-old boy. He was quietly suffering. The parents, with all of their resources, were struggling, believe it or not, to find the right help at the right time for this young boy. One night at about 3 o'clock in the morning, I got a phone call from my friend, and my friend said to me, John, Asher's gone. And initially I thought to myself, well, he must have run away. I said, let me get my clothes on, let me get to your house. We'll figure this out, and so let me get there. And he said, no, John, you don't understand. We found Asher dead in his bedroom because he shot himself. So that really shook the whole community, because a 16-year-old boy, that is not supposed to happen to anybody, let alone somebody at 16 with an entire life ahead of them. I went to the funeral. It was a very small funeral. I had my son. My daughter at the time was too young. My wife and Diane and I brought my son Ben, because I wanted him to be at that funeral, and to see the casket roll out of the hearse, and to see the casket put into the ground and the parents being pulled back from the grave forever touched me. And as a healthcare leader in that community, I even felt guilty feeling this, but I felt like we failed that family because we did not have the infrastructure, we did not have the systems, we did not have the programs, we did not have things for early warning signs, and a young life was lost. And if it could happen to this individual with this type of family, I thought to myself, it could happen to anybody. And if you think about that for a second and you think about what makes a community vibrant, one of the things that make a community vibrant is the ability for a community to take care of the most vulnerable. I tell my children oftentimes that one of the hallmarks of any great society, any great community, is the more fortunate give to the less fortunate in their time, in their talent, in their treasure. And that's what we need to do here when we think about addiction. Because any life lost is unacceptable when it comes to mental health issues and addiction. And that's what tonight is about. Because you are going to hear from some very engaged leaders, people that are very passionate, people that are working hard for our community and for our region, all across Tampa Bay. Did you know that more than 50,000 people die every year from opioid overdoses in the United States? Thousands more are affected every day. Many of you here tonight may be suffering. Maybe you've lost a loved one. Maybe you have a family member suffering. We hope that both our community panel and healthcare panel will educate and create awareness about how we together can combat this epidemic. Between 2016 and 2017, Florida emergency departments saw an 18% increase in overall opioid ED visits. The numbers continue to rise. That's why we must come together to dig deeper to stop this epidemic. Tonight you will hear from law enforcement and leading experts who specialize in behavioral health and community mental health wellness on our community panel. A little later, you'll hear from our healthcare professionals, physicians who are leading the way to help patients and families. The opioid epidemic is not the only health crisis happening. We are all staying alert about the coronavirus, and that really is a bit of the elephant in the room, and our mayor in a moment will address that ever so briefly. This week, I had the opportunity to be with Governor DeSantis, who declared a health state of emergency in the state of Florida. I can tell you, after meeting with the mayor, after meeting with law enforcement yesterday in a panel discussion with our governor and the Surgeon General, this state is prepared, the health system is prepared. We will take care of our healthcare workers first, because you are the first line of defense, and we will walk shoulder and shoulder with you through this. But we will hear, and we will maintain a united front for our community and for our team. And together we are going to work to keep this community safe. Now, with that said, I'd like to introduce and invite Mayor Jane Castor to the stage tonight for her opening remarks. Enjoy the evening, everybody, and thank you.
Thank you, John. I'm very, very honored to be here. There are a lot of individuals in white coats back there, which was very unsettling until I realized they're not here for me. Oh, that could have been trouble. So with the coronavirus, as John said, we met with the governor and the Surgeon General yesterday, and we do have a confirmed case, probably 2 in the city of Tampa, individual who had flown back, and her companion that had flown back from Italy, an area that had been infected with the coronavirus. And they both self-isolated and were tested on, the one individual was tested on Saturday and came back presumptive positive, which means that it had to be sent to the CDC in Atlanta to be tested. There will be more cases, there's no doubt about that, because we just received the ability to test on Saturday. So there will be more cases coming. But here is 2 very simple points that I make over and over and over. Follow the instructions to avoid contracting the coronavirus. And it's very simple, just like the influenza. Wash your hands for 20 seconds at a time. Use the hand sanitizer. We have some wonderful hand sanitizer up here. It's warm vanilla. We're not sure how you can tell warm from cold vanilla, but it's warm. But make sure that you use that hand sanitizer. Stay away from individuals who are sick. Stay home if you're sick. Try to avoid touching your face. Just those simple tasks that can be repeated over and over and over again will keep the majority of individuals from contracting it. And then secondly is get your information from a valid source. Get information from the CDC, from the State Department of Health, or from the City of Tampa, tampagov.net. You can go there. We have all types of instructions, numbers to call, or you can text Tampa Ready to 888-777, or for Spanish-speaking individuals, Tampa Lista, that's Lista, to 888-777. So very, very simple. We can't have individuals in our community panicking. As John said, we are very, very well prepared. We exercise for this type of an event in emergency management with everyone, with first responders, with the health providers, and everyone in our community. So that's it for the coronavirus for this evening. And you're not supposed to be shaking hands, and we've all hugged and shook hands about 50 times in the back, so we have violated that over and over. But one of the things I want to talk, this is a pretty heavy topic here about the opioid addiction, and it's something that as a law enforcement officer for 31 years that I witnessed firsthand, and it's a very, very important topic to our community. I personally believe that we will learn more about addiction in the next 10 years than anything else. It's a health issue, and I know that you'll hear a lot about this. I want to start with the crack cocaine epidemic in the 80s. That hit us like a tidal wave. I mean, overnight, the crack cocaine epidemic just destroyed African American neighborhoods and in communities throughout the United States. And the response to that was to try to go in and arrest our way out of that epidemic, out of that problem. And that really was a mistake. And so as the opioid addiction has come forward, we're looking at it more from the disease aspect than from the criminal aspect. And I believe that that's the right thing to do, without a doubt. Now, from the crack cocaine, fast forward to, say, the late 2000, around 2007, 8, 9, around there, we got hit with this opioid and distribution network. And we, by virtue, and when I say we, I mean the state of Florida, we had no pharmaceutical database. And so we had individuals from other states. We were the supplier state. And people would come down in vans with groups of addicts, and they would go down the West Coast and up the East Coast to pain clinics. And the state of Florida at one point was supplying 85% of the nation's oxycodone, 85%. And so we were finally, through our Attorney General in the state, we were able to get a pharmaceutical database, and that pretty much put an end to the opioid crisis, but you still had all of those individuals that were addicted to the opioids. So now you have the street level sales of all of that, and they became so expensive that individuals turned to heroin. And then we had the issue with the fentanyl and the overdoses. And I actually was on a law enforcement advisory, one of the coolest assignments I ever had, law enforcement advisory committee to the National Director of Intelligence. And the individual who was the head of the New Jersey State Police, Rick Fuentes, he told me, he goes, Jane, this heroin is going to hit you guys just like crack cocaine did. He said it is the crack cocaine of this decade. And it was the #1 killer up in New Jersey at that particular time. So as a chief of police, I called around to the hospitals and ensured that we were tracking the deaths and the overdoses that were coming in. And that process didn't really get in place as well as it should have in a quick fashion. And so you'll hear a little bit more from that from law enforcement. We didn't have our communication down tight between first responders and the health providers as well. But we have to make sure that we are all working together, and that's what you're going to hear again from law enforcement and from the health providers. This type of addiction, you know, it really hit home with me in a number of different ways. One, we had a couple of police officers that were injured and ended up becoming addicted to opioids. One in particular was a really big, strapping individual, and he became addicted to opioids, and we sent him through rehab twice, and he ended up being fired from the department for prescription fraud, and he literally died out on the streets as a heroin addict. And it's just so sad to see those types of things. And I know there's a million stories. You'll see one in the end here too that are just heart-wrenching. But something that really hit it home for me was I was watching a documentary one night, and there was a woman who was an attorney. She was in a car accident, and she went to the hospital, and they gave her opioids. And she said the second that hit her bloodstream, she goes, I was an addict. So you just think about that. That is all the more reason to look at this as a health issue. And I know that there are a lot of techniques now. I moderated an opioid panel with physicians, and they talked about some of the surgeries that they did on extremities that they were using nerve blocks as opposed to providing narcotics for those. And then also having patients manage pain and understand that there will be some pain associated with injuries and with operations, and that, you know, we don't have to take enough drugs to eradicate all the pain. But this is such an important issue because we are losing so many individuals from all walks of life. Addiction does not know any boundaries, and so it's something that we all have to work together to address. And quite often, the mental illness and the addiction issues go hand in hand, and we see that a lot out on the streets for the city of Tampa. So I thank Tampa General Hospital for putting this on tonight. I thank them mostly for not taking me away, the one in the white coats. But I'm such a fan of all of the first responders in the emergency room personnel, because that's where I was first assigned as a police officer. And the individuals that work in the emergency rooms do amazing things 24 hours a day. So now I get to introduce the moderator for this evening, and this is someone who is near and dear to me. She's a former TV news reporter, anchor, and we spent a decade at the police department. I was one of the ones that wrangled her away from the media. She was my communications director for TPD, and that means that what she did is she followed me around saying, what the chief meant to say was this. She didn't really mean what she just told you. But now Laura McElroy is nationally recognized and travels across the country training law enforcement on strategic communications. So, and this is the person, Laura McElroy, that if my boat was going under, I would grab her. And not because she is an excellent flotation device, but because she is an incredible, incredible communicator and crisis communication handler. Come on in, Laura.
Remind me not to get into a boat with Jane Castor anytime soon. I know that I'm supposed to call you mayor, but you'll always be my chief.
No, there you go. That's good.
But she's not my daughter's chief. My daughter came to visit me at work when she was just 3 years old, and she was morbidly shy and is hiding behind my leg, and Jane is telling her, you know, Jane, of course, in her uniform, standing 6 foot tall, is a little bit intimidating to a 3-year-old. So she tells her, that's okay, you don't have to talk to me. Just tell me, who is your favorite police chief? And all of a sudden, my morbidly shy daughter comes out from around my leg and clenches her fists and looks up at the chief and says, "My mommy."
Oh, well, that'd be somebody's favorite, chief.
Kids will say the darndest things.
There you go. All right, well, you guys are in good hands. Thank you so much for being here this evening. This is going to be an outstanding event. Thank you all, and God bless.
All right, so it is now time to get down to business, and we want to bring out our first panel of experts, and I'm just going to ask you to hold the applause until the final panelist takes their seat. First up, we have Sheriff Chad Chronister, a veteran law enforcement officer who has served with the Hillsborough County Sheriff's Office since 1992, and whether he was working as a patrol officer or as a detective or as a member of the SWAT team, Sheriff Chronister has always seen his profession as more of a calling to help others. And that's exactly what his programs are doing, his jail programs are doing, to help people who are addicted to opioids. Next up, we have Chief Brian Dugan from the Tampa Police Department. I already promised Chief Dugan I wouldn't tell any stories about him from back in the day at TPD. During his 28-year career, Chief Dugan has worked in pretty much every facet of the Tampa Police Department, giving him a very diverse background, and which has really made him into the progressive leader that he is today. And it's very evident in the program that they're standing up right now to try and help people who are addicted to get into treatment rather than to end up in the county jail. Great to have you here, Chief. We're also fortunate to welcome Sheriff Chris Nacco from the Pasco County Sheriff's Office. Sheriff Nacco has held this position since 2011, first appointed by then Governor Rick Scott and since elected to the post. Sheriff Nacco was one of the first responders to the 9/11 attacks and to the DC sniper cases. He also has some very cutting-edge programs in place that focus more on prevention than on penalties, and he'll be, of course, sharing them with us tonight. Next, we want to welcome to the stage Carrie Zeiss, President and CEO of the West Central Florida Mental Wellness Coalition. 30 local groups created this coalition last year to make mental health treatment more accessible to our community members, and they address depression, anxiety, and of course, substance abuse and addiction. We want to welcome Mary Lynn Ulrey to the stage, the Chief Executive Officer of DACO Behavioral Health Incorporated. Mary Lynn is a Tampa native and a psychiatric mental health practitioner. And finally, we welcome Gail Ryder, Vice President of Baycare Behavioral Health. Gail is responsible for the continuum of services across the 5 counties of Tampa Bay for Baycare Behavioral Health. How about a round of applause for our panel? I want to thank you all for being here tonight and taking the time to be part of such an important discussion. And I want to start by diving right into the law enforcement perspective. As first responders, you all really have your pulse on the finger, your finger on the pulse of this issue. So to give us a baseline, can you tell us where do we stand right now? Are we making progress? Are overdoses up? Are they down? Kind of give us a synopsis. And I'd like all 3 of you to answer, and if we could start with Sheriff Chronister.
Sure. The bad news is we've had 670 drug-related overdose deaths over the last 3 years. The good news is those deaths and that death rate is a lot lower than even some different counties south of us and some different places in the nation. When you talk about 670, some have 6,000, 60,000. But I think I speak for all of us when I say one is one too many. Do I think we've made some strides? We have, and it's because of education forums like this. You know, we talk about treatment, we talk about enforcement. We've come such a long way. So I think if I had to say something, it would be something positive, and it's that we're making tremendous progress, but I'm going to not kid anybody or lose any credibility here. We still have a long way to go.
Long way to go. And Chief Dugan, how about in the city of Tampa? Are we seeing that kind of progress?
You know, I think we're making progress in our strategy, but it doesn't feel like we're making progress in the problem. You know, the number of Narcan deployments we've done has increased dramatically. I think we had 152 or so around there last year. We had about 60 deaths within the city, but that's just TPD. That's not counting fire rescue and other things. So it's a much broader problem out there, and that's what I think where we're struggling in law enforcement is getting the information from everyone.
And I know this is a topic that you're very passionate about, Sheriff Nocco. Tell us how things are in Pasco County. Do you feel like you guys are making progress there?
Well, I think along with my partners up here, we would state this is a healthcare issue. Mental health and substance abuse are healthcare issues. Unfortunately, law enforcement, fire rescue, we're the first responders out there, so we're the first ones on the situations. What we're seeing right now, our overdoses are going up. There is, unfortunately, I can tell you that fentanyl is the same price of heroin. And so before, what we were hearing from the drug addicts out there who were looking for the high was they were surprised that there was fentanyl in the drug. Then they started asking for fentanyl. So is that in the drug? Now they are just asking for pure fentanyl. So when you talk about issues in our community, this is a healthcare issue. And like we heard from the sheriff and the chief, we're seeing addiction is being dealt with out there by first responders, but we have to address this, change the formula. I'll be the first to admit the war on drugs isn't working too well. This is a healthcare issue. It's not a law enforcement issue, and we need to start addressing it differently because we're just spinning the wheels again.
And so we always think, of course, of first responders, fire, and police. But do we have to expand that? And I've heard you talk about that, Sheriff Nocco, that maybe first responders in the future look a little different. Of course, we'll always have fire and police, but
Right.
What's next?
That's one of the things we were discussing is the fact that you're going to have law enforcement. You're going to have critical situations that law enforcement have to respond to. You're going to have fire rescue. They're going to have to respond to different scenes, fire scenes or crashes. But there needs to be a third first responder. It needs to be the medical field. Because if you ever sit in dispatch and you hear calls come in, they're medical calls. One of the things we're working on right now, we have a behavioral health team that goes out there and they're acting in the role of the medical professionals, but we have to fill that void because there's so many people that need help. But one of the things we're working with at St. Leo University is getting interns. So we can go out there and visit those people, not from a law enforcement perspective, but from a healthcare perspective, from a social worker's perspective. So I think in the future, with technology, the way it's going, property crimes are going to decrease over time. With the critical situations, law enforcement's going to have to respond. But the healthcare epidemics of what we're seeing are growing and growing. So I think in the future, you're going to have first responders that are medical, and they're going to be responding to scenes, and that's what dispatch is going to send out first, are the medical providers.
And TPD is already starting to move in that direction. Can you share with us, Chief Dugan, about your program where you're going to send social workers out with detectives, officers who are responding to overdoses?
Yeah, we currently we received a grant for about $900,000, and the plan is currently whenever we have an overdose, we send 2 detectives out, and we try to debrief the person who overdosed, and we try to get as much information as we can from them, and then we offer them help. But they're reluctant to receive help from law enforcement, and I get that. They want to kind of just distance themselves from the cops when they just overdosed and we brought them back to life with Narcan. But the plan is to take a social worker with us to these, and that's what the grant's going to do. And then furthermore, part of the grant is we'll be able to get them into some type of recovery program so that we can kind of stop the cycle. And we are going to be partnering with USF, and so it's a unique approach of taking a social worker with us so that we can do the law enforcement investigation part of it, but have medical people there that can get them the help to kind of break the cycle of it all.
And one thing that you learn working in a police department is that they are not just enforcers. They're also guardians, they're big brothers, they're mentors, they're counselors. And have you seen a growth in that area as well, Sheriff Castor, that you are working more as a social worker sometimes when a deputy goes out versus just being an enforcer?
100%. When you think of law enforcement, you think, oh, they lock everybody up. And the mayor alluded to it in her opening remarks. Our strategies have changed. In the height of the crack cocaine era, that's what we were deployed to do, lock everybody up. We realized we weren't going to arrest our way out of any type of problem. And the opioid and the mental health epidemic that we're facing now, and most of the times they're codependent. You have people suffering from mental health. they're not getting any type of formalized treatment. So what they do is they self-medicate with opioids, with any type of illicit drug. That's how they end up coming to our detention facility. So when you talk about where we've made our progress and where the expansion has been, yes, it certainly has been in enforcement. We have a heroin task force, and we've put some homicide detectives on this task force, and they work monitoring the drug overdoses, and we go back and research to hold those dealers accountable. With the new state law that was passed, it's worked beautifully. Matter of fact, working with our sister agency, Tampa Police Department, we've done 4 heroin search warrants in the past week, and they've been extremely productive. With the new law, now it's, hey, listen, you deal, they die, you're responsible. So I say that, and we're proud of that. But again, it's such a small part of what we do, and that's what you were talking about, Laura. We actually took this holistic approach in our detention facility. We have 3,000 to 3,200 inmates in our jails. Our detention facilities at any given day is our daily jail population. Well, what we realized is we were just warehousing prisoners. They would come in, they would do their time, and they would leave, and then we sat there and scratched our heads, why are they coming back? We knew we had to do something different, so where we've expanded our resources is getting them additional drug treatment, mental health treatment. Sometimes it's treatment that we do together. We have a particular mental health pod just to keep them separate so they can work together, group therapy. But we've had more mental health practitioners and more drug treatment counselors, and also working with DACO, a wonderful resource in our community, to work with them. It's done such a wonderful job that we've actually seen the recidivism rates go down. And the last missing piece of this is they get their education, they get their treatment, we're making people healthier. So we're not seeing them as often. When they leave, we make sure we work with the county, and I was able to get them to fund a 30-day prescription. So when they get their medication, they leave, and now they're not getting the treatment, they're not getting the medication. Then again, we scratch our heads wondering why they're coming back to our facilities. Now they get 30 days worth of medication when they leave. That gives us, like Sheriff Naku said, that gives us, we split the county up into 5 districts. We have a deputy in each patrol district that is a behavioral health deputy that goes out and looks at the high utilizers of mental health. But we also have a social worker on the east side and the west side of the county that goes out, hey, listen, here's the resources available. How can we continue this treatment and make you healthier? Again, so you don't find yourself back under arrest in one of our detention facilities.
Well, speaking of community resources, there's a brand new coalition in the Bay Area, and I'm sure that because they're so new, that probably a lot of people, Carrie, don't even realize that the coalition exists yet. So can you tell us how you were formed, and really what is your focus with trying to combat this crisis?
Absolutely. In 2019, 30 community leaders convened to have a really in-depth discussion. You've heard the statistics. This is a crisis, behavioral health, mental wellness, of which opioid addiction is one of those subcomponents. That is something that continues to show up in all of the community needs of health assessments across the 4-county area of Hillsborough, Pinellas, Pasco, and Polk counties. And these leaders came together for 2 days, once in January, once in March, to talk about how they could approach working together a little differently. And in that discussion, there was a decision to stand up a freestanding nonprofit, a 501c3, which is the coalition, the West Central Florida Mental Wellness Coalition. I was just hired in January to lead that coalition. This is a table full of decision makers and people who are highly invested in really moving the outcomes to make access to mental health easier, to help people who are in crisis more efficiently and more effectively across various organizations. And then once those 2 areas of access and urgent care intervention are stood up, we'll be focusing on a destigmatization marketing campaign. We want to make sure that people know it's okay to ask for help, and then they know how to get that help once those solutions are stood up.
And so you'll really help people connect with those resources that are out there.
Right.
That often somebody's looking for help, they don't know where to go. And then because they don't know where to go, they don't get the help, they end up in crisis. So it sounds like you guys are the middleman that will make that connection.
Right. We have currently a work group that's focused on navigation, navigation is where do you go to find help? How do you navigate the questions that you have when you don't know what the issue truly is yet? How do you get connected in a timely manner to resources that can help you? So this is a resource for people who are actively seeking help, but need a little assistance to get to that final destination. The next work group that we're standing up, of which Gail is part of the leadership, is our behavioral health care, urgent care group. So that's once you're in crisis, where can you go to get help fast? If you have a family member or if it's yourself, before you're actually at the point that there's a action that's taken, like a Baker Act. How do we make sure that we de-escalate the points of care for people so that they can help before they're really in urgent crisis?
Such a needed resource. We're glad to have you. I want to get into the nitty-gritty of treatment with you, Mary Lynn. I think a lot of people probably don't realize that you don't have to detox off of an opiate before you can start medically assisted treatment. Can you talk to us about that?
Absolutely. A lot of people think that you have to go to detox first, and in fact, I sit on the governor's opioid panel, and one of the things that some of the people from the sheriff's offices thought you had to detox first, and you do not. The transition to medication-assisted treatment, which is now called medication treatment, because other medications are called treatment, it's now medication treatment for opioid disorders. The opioid treatment is just this medication opportunity, and I think it's really important to talk about why detox isn't necessary. People can go straight to a medication like they do in the Tampa General ER and then come to outpatient treatment for their opioid disorder. So that's been a real transition for lots of folks here in Hillsborough County. We have about 15 people that come in every day. We have a walk-in. People don't make appointments for opioid disorders or other substance use disorders. They don't keep their appointments, so we don't make appointments. We have about 15 people that come in every day, and today 4 or 5 people came in for opioid crisis, and we put them directly on medication. So they don't have to go to detox. I think that's really important to know.
And so once somebody does make that decision that they are ready to get help, how does that detox occur?
They don't detox. They transition to a medication. The opiates that they use last 4 to 6 hours. So every 4 to 6 hours, they have to have another dose of whatever they're chasing. So their lives are chaotic. They're looking every 4 to 6 hours. That's 6 times a day if you look every 4 hours. Once you're on a medication for this, they transition to the medication. It's once a day. It lasts 24 to 36 hours. So people aren't in crisis anymore, and they actually can have a job, and they actually can function on a regular basis. So those are the positives of medication-assisted treatment or opiate medicine treatment.
So there's so much focus on the opioid crisis. Does that mean that we're overlooking or ignoring the other substance abuse issues or addiction issues, Gail?
No. Like I said, we had many people come in just today. Every day, 10 to 20 people show up. But the opioid people aren't coming like they should. We have a lot more people that need services that don't make it. And I hear the Baker Act mentioned, but people aren't talking about the Marchman Act and using the Marchman Act.
And do you want to answer that question as well, Gail? Do you feel like some of the other issues are being overlooked because of it, or are we benefiting because there's so much focus on it?
I think there's both parts to that.
Okay.
I think when the opioid crisis showed up and there was actually medicine to help, it was a very exciting moment for those of us who've been dealing with people with addiction, for me, for 40 some odd years. It's a nasty, sad, debilitating, demoralizing illness. For those of us who work in this field, you're trying to help someone, the relapse rate is wildly high, you don't see any, it's so hard to see people do well. So all of a sudden here we have this crisis, but we have medicine. And it was very exciting to watch, giving someone the medicine, letting them get their lives pulled together, and then putting them through a successful course of treatment, which is very exciting. But at the same time, what ultimately happened was it's very hard just to find someone who's addicted to opiates. They're addicted to methamphetamines or alcohol. It's never just the opiate. So it's a very complex illness. So from that perspective, I think those of us who work in this field, addiction is it. So how do we take what we've learned from opiate treatment and try to apply it in other areas of addiction? Because we're not, as Chief Chronister said, we're not really getting anywhere. You know, so we're at the tip of the iceberg, we're at the tip where we're learning things, and how do we carry that forward? So.
Is there enough funding? Is there funding to put the programs in place to offer the treatment, to offer the mental health support that they need?
Ah, the big word, big
Money.
Funding word. You know, again, plus minus. So the plus is there's money. And there's money for prescribed things. And I think as time goes on and as the people who provide the funding learn about what we need, they are starting to open the gates to more things. An example, we have access to the medicines for the people who want to get into treatment. That's a good thing. But if they're so involved and we really need to get them into residential treatment, it was hard to get them there because the funding wasn't necessarily there for that. That's opening up and moving along in the right direction. So the funding is critical. It saves lives. But I want to go back to answer the other part of your question, which was, how has it changed us as providers? So, as Mary Lynn said, you just have to have your doors open. You have to be there at all hours. You have to pay attention to our safety officers and our emergency rooms, because you have them at a point where they might be willing to say, okay, I've had enough. Mm-hmm. And when they say I've had enough, you have to be there. You can't say I'll see you at 7 in the morning. So we as providers have had to shake our systems up to accommodate that reality. And that has opened the doors to a lot of different ways that we work. So things are changing. I think I share our safety officers' perspective. I wish it was faster, but when you think you're on top of it, now here comes methamphetamines and cocaine and everything else that's out there. So I think we just have to work better together, and we have to work faster.
And Mary Lynn, we all know that change is difficult, change is slow, and that's really a change in culture of the way that you're doing business. Is that something that you feel you're making progress on as a profession, of really trying to respond more quickly and to be responsive to the critical need?
Even the staff were not used to medications being available for addiction. Addiction meant you couldn't have anything. Mm-hmm. So for our staff to come around and realize that medication-assisted treatment or medications for opioid addiction were okay in the residential setting or wherever they may be was a huge change in culture shift for staff. But we've been very lucky in the staff that we have, and they're very welcoming. I just know that there are hundreds of people out there that need this help. If all 100 came every day, we would not have enough money. Today we have enough money. So.
Well, and the culture shift applies to law enforcement as well. And I worked with cops long enough to know there's only two things they don't like, and that is the way things are and change. But they are changing. And both sheriff's offices have set up programs where people who are calling 911 on a regular basis for mental health issues, for overdoses, that now it's not just a deputy that shows up at your house, but it's a deputy that is trained in behavioral health. And Sheriff Chronister started out discussing what they do in Hillsborough County, that you have one assigned to each one of the districts, which is terrific, because then the people actually have a chance of getting the help they need. And tell us about your team that you've created, that you have a whole team in Pasco County that responds to overdoses and to the regular callers for mental health.
Yes, we have a behavioral health intervention team. So both sides of the schedule, we have 12 detectives along with case managers, and we work directly with Baycare, who's been a fantastic partner. So what they'll do is, right now they have 270 people that the most prolific people that were calling 911. And so they're working, they go out directly to them and say, you know, what can we do? What can we help you with? And it's interesting because a lot of times they just want to talk to somebody. And so that's something that we're trying to get out there, because patrol deputies, they just want to go to the next call. They want to go to the next busy call, go to the next call. And these people, they want more time, they want more attention. But we're trying to save them because we know these are the people that are most likely to attempt suicide. And so what we also want to do is provide that warm handoff to a case manager. We want to be able to provide Baycare to help them. And it's interesting, a couple of things that we've been looking at is saying, you know, we're downstream already. We're down by the point this happened. These people are in crisis a lot of times. So we keep trying to go upstream. And so one of the things we're working with Dr. Brianna Fox from USF is inside the jail to take these individuals, and when they come in, they're being interviewed, and to find out why they have an addiction issue, what brought them into the jail, what brought them into this crisis that law enforcement had to intervene or make an arrest. And a lot of times you're finding a lot of people that have head injuries. A lot of things that we're looking at right now is that these people were victims of crimes in the past, and because of the tremendous traumatic impact they had, whether it been a rape, molestation, or some other type of crime, they were using that drug as basically something to hide or mask the pain that they were dealing with. So I think we have to keep going further upstream to identify victims at the very beginning and overload our assistance with victims. So because I think a lot of times we're finding out these are the ones that are ending up going to addiction because of the pain they're suffering with.
And these victims lots of times end up needing Narcan. Let's talk about Narcan. All three of your agencies now have all your officers, all your deputies carrying it. I've seen the video on body-worn camera video where someone has overdosed, and as you all know, working in the profession, you give them Narcan, and it's like a miracle. They just wake up. And so I want to talk about the way you're using it. If we can start with you, Chief Dugan, are you seeing an increase? Or in fact, I think you mentioned that you are seeing an increase in the number of Narcan uses with your officers.
Yeah, we have an increase in it. We started back in November of 2017 purchasing Narcan for the officers. There was a bit of a urban legend and a scare in law enforcement that officers were being exposed to fentanyl and things like that, and there was concerns about officer safety. And back then, we really didn't know the problem that we had in the city of Tampa. There were some communication issues with the medical services and fire rescue, and there was some resistance to law enforcement even having Narcan. And so we were able to purchase some of it, put it in the hands of the cops, and I'll tell you, once we got it, we started handing it out like candy. And it was shocking to us. And now we're able to map where we're giving Narcan. We have fire rescue. We map that, and that's how we're attacking the problem. Narcan's been a tremendous tool for us, but it also is a little bit of an inhibitor sometimes because once we give Narcan and they're clean and sober, we don't have the ability to do a Marchman Act. We don't have the ability to do a Baker Act. It struggles for us. We've had people we've given Narcan to 2 and 3 times in the same day.
And do you find the same thing, Sheriff Chronister, that you have people out there that they're now using so many drugs they've become used to and expect to get Narcan from law enforcement?
Yeah, and what law enforcement's finding is where we would give a single dose that's not working, they've built up a tolerance. So now our deputies are given a second, even a third dose to bring them back. Matter of fact, right before Christmas, we've had 31 Narcan deployments between December and the end of February.
Wow.
And we had someone just before Christmas, 2 days before Christmas, and she was overdosing. They had to give her several doses of Narcan. She's no response, no pulse, nothing. I mean, you want to talk about a miracle drug. The deputy says she sits up, she takes a great big deep gasp of air, and she goes, "Wow, my children almost had to bury me on Christmas Day."
Wow.
So we're seeing it. And again, this tolerance that's being built because now they know that safety net's there, so they're not as concerned. Listen, there's a tremendous concern that these profit-driven drug dealers, they're cutting it with whatever they can to maximize their profits. They don't care who it hurts.
Right.
And our communities are paying a tremendous price because of it.
Well, and then using the Narcan gives them the opportunity that that might be their time that they reach their bottom and ask for help.
And that is happening. I don't want to allude to the fact that, hey, listen, they're good. A lot of times that's a wake-up call for a lot of individuals. We even created a drug amnesty program to where now if they bring their drugs, they call us, they come to any of the sheriff's office facilities, and they come in and say, "Here's my drugs, I need help." We'll give them a ride to DACO.
And Mary Lynn, Gail, are you aware of any stories where people have turned to treatment after they had Narcan from law enforcement or from an ER?
Absolutely, absolutely. Not to, it's the Narcan, but it's the talent of the people who engage with the individual and share the hope stories. And if you find a caring individual in our police officers, in our emergency rooms, who are going to go the distance to make that handoff happen, they will connect.
Anything you want to add, Mary Lynn?
I do. We worked with, I think it was Officer Washington came over from the Tampa Police Department and met with us and said, we're going to be going into these houses where the drug dealers are, and if we find other people there, can we bring them here? And I said, absolutely, and just don't bring the dealer. So he said, we won't. So we have enough people here that would be beneficial, would want to benefit from that. The other thing is we have people that actually come in for help and will be sitting in the waiting room to see the doctor and fall out, and we'll have to Narcan somebody there. And then, because they think they'll get in trouble, they want to go get in their car, and I've stood behind their car so they don't leave, so we can get them the medicine that they need. So it's an
That's
amazing
incredible.
thing to be an addict and want this so badly, you will just do anything to, we've got to be careful and caring, and peers have been a really positive impact on this. In our lifetime, we've never seen peers, people who've been through and recovered from something and have 7 or 10 years under their belt will actually talk to people in different settings and get them to engage in treatment, and that's been a real positive.
Which is terrific to hear those success stories.
Yes.
So I've learned that Sheriff Nacco always has Narcan on him. So can you show it to us tonight?
Yes, this is our Narcan that we all carry. Most of us have multiple because, like Chief Dugan was saying, for officer safety, but it's also our canine safety. Because they'd be the first ones that probably get the contact with it. But it's interesting, you talk about the numbers. In Pasco, we had 44 deployments in 2017. In 2018, we had 77. In 2019, we had 221. Wow. And fire rescue has probably 3 to 4 times that. But the reason why those numbers are, it's every can that you give. So we've had people we had to get six cans to, 6 doses of Narcan to bring them back. And, you know, that's what I said, they're building that immune system because they're asking for straight fentanyl. One of the things that we do, similar to Sheriff Cronister's team, is that we work with Baycare. So if somebody survives the overdose, we go to them afterwards with our behavioral health team and say, would you like help? So about 30% said, well, I'm interested in help. But then it goes back to the funding issue. There's not enough help out there. And so one of the things that we're looking at is, you know, everybody has iPads, everybody has cell phones, you know, is have the teledoc, but for psychiatrists and psychologists. So that they can immediately, because one of the things, one of the biggest failures that I think our behavioral health team feels is that these people want help. They're like, yep, I'm in, I want to do something, and then 2 months getting them in is a quick time. Usually it takes somebody 4 months. So what we want to do is get as quick as we can, so that is a desperate need out in our community, is getting more help for those that want and desire to be successful in recovery.
So I want to ask this last question to everybody on the panel. In the news business, we call this the lightning round, where everybody answers a quick synopsis on the same question. And the question is, if there are people in the audience tonight who have family members, who have friends, who know someone who needs help, or even just from a professional perspective, what is the first step that someone should take if they are trying to get help or trying to help someone get to that point where they're ready to reach out? Let's start with you, Gail.
Be confident that there's treatment out there. Be confident that treatment works. Give hope and encouragement, and hold their hand to get them where they need to go.
Great advice.
Yeah.
Mary Lynn?
I would say all those are an excellent answer, but people are not using the Marchman Act as readily as they would the Baker Act. And I think people need to realize the Marchman Act is there to be used for people that won't get help or refuse to get help. A family member can do that, and I think it's really important to utilize that if nothing else is working. If the
Quickly tell people, what is the Marchman Act?
The Marchman Act is like the Baker Act. You can go down to the court and fill out paperwork and have that person, of course, the sheriff and the police chief can do that without going to court. But if you're a family member, you would go to court, you'd fill out a paper and say why you think this person needs help, and the police will pick them up and take them to a treatment center for them to get the help that they need. And rather than them die, I'd rather see you do that. And they will be mad at you for a while, and they'll get over it because they'll get better.
Which that act really gives family members a tool, which
Yep.
they didn't have before. Carrie?
Another resource that you could use is to call 211, which is a number that will connect you to health services information and referral. So they can help you figure out where to begin to access services and just get to the next step.
Sheriff Nacco?
The one thing is, don't think rationally, because they're not. When somebody's on addiction, they don't think rationally, and they'll tell you, when you talk to people who've survived addiction, they'll tell you that. I don't think rationally when I'm seeking drugs. But then when you're talking to them, try to get to the root of the problem. Don't talk about the addiction, talk to them about what caused that addiction and try to get them help for what caused them to get into the cycle that they're in.
Chief Dugan?
And I think the spin-off of that, when you are dealing with someone who's dealing with an addiction, you have to keep in mind, you have to be factual. You can't let your emotions, your attachment to that person, cloud your thinking. They're probably lying to you, quite frankly, because they don't want to admit that they have a problem. And so you have to be very factual, be an investigator, and not take any of their answers at face value and not lie to yourself.
Which is tough to do when you love someone. Sheriff Cronister, last but not least.
Last, what am I supposed to say now? Being the last one. No, but I think it's important to never give up. All of us here, we have family members too. I have a 24-year-old son who's sitting in state prison because he's an addict and he refused to get help. Don't give up on him. Be there for him. Make sure they can count on you to be the symbol of hope and help. Never give up on them. We all have to realize as a community and change the culture, whether it's mental health or drug addiction, that it's okay to not be okay. It's okay to ask for help, and we have to know that addicts aren't bad people. They're people that are suffering from a disease who need help, not jail.
Well, you heard it straight from the people. These are the people who are on the front line of dealing with this crisis, and we so appreciate the time that you dedicated to this conversation tonight. Such an important issue. We've made progress. We still have a long way to go. So another round of applause as they exit the stage. Thank you. Thank you so much. Are we allowed to shake hands? Thank you. Thank you. Thank you, Carrie. I really appreciate it. All right. A hug for my former chief. I got to hug everybody, even though I know you're not supposed to right now. Thank you, Sheriff. In January of this year, heroin and fentanyl continue to be the most common drugs that individuals overdose on. In fact, the age group of 25 to 34 is the group that has the highest number of opioid-caused deaths, and it's also the highest number of opioid-related emergency department visits and hospital stays. This is real. It's happening across our country. It's happening right here in Tampa Bay. Tonight we have someone brave enough to share her own personal story, her story of love, her story of loss. And tonight, she is helping others with the power of speaking out.
My name is Candace Amato. I'm the Director of Nursing for the Medicine Division at Tampa General Hospital. I had my son when I was a senior in high school. After I graduated, I went to nursing school. I knew that that was my calling. I was very excited to get started. Going to school, going to work, I did not get a lot of sleep. Now I think back, I have absolutely no idea how I did it, but I knew that it was not just about me. Zach had an accident between his 7th and 8th grade year. He crossed in front of an excursion and was hit and thrown 25 feet. His friend who was with him thought he was dead. When they called me, they had no idea if he was gonna even wake up. He ended up being in the ICU at a nearby children's hospital for about 5 days. They prescribed him opioids at that point, 13. So first taste of narcotics. So I found this out later, but apparently with the pain clinics, they just required an MRI. I heard that he was able to get prescriptions for OxyContin. I was obviously living in La La Land. Unfortunately, I think that sometimes people think about addiction and it has something, it's a socioeconomic issue. It absolutely isn't. I never ever saw him drinking. I never smelled pot on him. But what they would do is go to parties and everybody would bring what was in medicine cabinets. Zachary was 17 before I realized that we had a problem. And then we were trying to play catch up. It was like a terminal illness. That is how I would describe it. He was a smart kid who was doing stupid things. This was somebody who was my best friend. Like, how could you do this to yourself? Like, you're killing yourself, and I'm watching. And then it gets to a point where you just have to start mentally preparing yourself. So I walked in the room and I saw him. It looked like he was praying. And I said, what are you doing? And I touched him and as soon as I touched him, I knew that he was gone. I'm a nurse. I just remember trying to catch my breath, collect my thoughts, because I knew that no amount of CPR, there was nothing that I could do at that point for Zachary. What I needed to do now was try to figure out how I was going to tell my little boy that his brother was dead. This is the hardest thing that I've ever had to do. I don't know how to tell you this, and I don't know if this is the right way to say it. I just found your brother. And he wasn't breathing, and I can't save him. But what makes me love Tampa General is that it was the people. Again, why I love this job. It was the people here who helped me carry the grief and who helped me keep on going. I can't imagine what I would have done without them. That the majority of addicts started out thinking that they were going to be addicts, that they were going to lose control. We don't know what their history or their life is like, and it is pervasive in our society and our community. So many people feel shame and they keep it hidden, and they bear the weight of that on their shoulders. If all of us could be able to sit down and really, truly talk to our patients and make those connections, that is the special part of this job, the people, and to be able to connect. I think that makes such an impact, and that connection from the heart.
Please welcome to the stage, from Tampa General Hospital, Dr. Laura Hopner, Senior Vice President and Chief Quality Officer.
Thank you. And that applause really should be turned toward Candace. Candace, I am so sorry that you've experienced that. And it's so important that you took the time and were so brave to tell that story for all of us tonight. So many people feel ashamed and keeping this hidden, bearing that weight on their shoulders. If all of us could just sit down and make that connection. Many of you already know Candace is one of our fabulous nurse leaders at Tampa General, and we all owe her a huge debt of gratitude by being brave enough to speak out, saving lives by doing so, and letting people know that it's okay to ask for help and there is no shame. So again, Candace, thank you so much. So we're here tonight really in honor of Patient Safety Awareness Week, which actually is next week. And as the Chief Quality Officer at Tampa General, remind everyone that we started on this journey to zero harm. And that journey does not just pertain to the four walls of our hospital. We are talking about zero harm for our patients, our team members, our physicians, and our community. And we're learning a lot about safety science in healthcare. We know that human error is inevitable, and what we are trying to do is prevent, anticipate, and mitigate that error so that there is no harm to our patients, team members, and community. So it is really crucial to bring that back tonight and think about that as we are here listening to our great community leaders, and what you'll hear next, listening to our healthcare providers as well about how we're tackling this. Because our charge at Tampa General is not only to practice safe care and learn all the evidence-based practices out there for preventing harm to patients, but also to innovate and lead in this field. So it's my pleasure to welcome the healthcare panelists tonight. I will ask you to please hold your applause to the end. First, we have Dr. Jason Wilson. Dr. Wilson is an emergency physician. He serves as the medical director of the Clinical Decision Unit at Tampa General and is an associate director of the Adult ED. Next, Dr. Hassan Mir joins us. He is a professor and residency program director at the USF Health Morsani College of Medicine and director of trauma research at Florida Orthopedic Institute. Following him is Dr. Maya Balakrishnan. She's an associate professor of pediatrics at the USF Health Morsani College of Medicine, a neonatologist, and she serves in many important quality improvement roles at TGH and USF. We also have Dr. Judette Lewis. She's the co-director of Women's and Children's Service Line at Tampa General and the new chair of obstetrics and gynecology at USF. Next, Dr. Christopher DeCoyne. Dr. DeCoyne is the medical director of bariatric surgery. We are lucky enough to just have him arrive to Tampa Bay just last year in 2019 from Tulane University School of Medicine. And we are happy to have him as part of our Tampa General and USF family today. Finally, we have Dr. Suvakam Puri. He is our current medical director of acute pain medicine and regional anesthesiology at Tampa General, and he's the fellowship director for regional anesthesiology as well. Thank you all for being here, and we all look forward to hearing about all of the wonderful things you are doing to help with this epidemic. Lastly, now I want to welcome back Laura McElroy to the stage so that she can begin our panel. Thank you, Laura.
Thank you so much. So let's start right away with the emergency department. How common is this for all of you in the ED?
You know, Laura, the mayor actually said something very interesting. About 10 or 12 years ago, we first started seeing opioid overdoses, people coming in with a complaint of opioid withdrawal, and that was kind of the first wave. But if we go back to that period of time a decade ago when I was training, we really had nothing to offer patients. They came in for these complaints, and we really maybe gave them a list of resources that were probably not going to be available to them, and then discharged them home. And so now we're in the second wave. What we see now is sort of the same types of things we saw 10 years ago, but much worse. And so we see both people coming in an overdose acutely, but we also see people coming in seeking help, recognizing their own withdrawal, or having other medical problems that are exacerbated by the fact they have underlying opioid issues.
We're tackling such a serious, such a heavy topic tonight, and I was speaking with Dr. Wilson before the event today, and he shared such a terrific story of inspiration and hope. So would you share it with us about the Narcan use and leading to somebody really getting help?
Sure. So first of all, I think that utilizing Narcan in an emergency department, when I trained, Narcan was a drug we gave in the ED. It was a drug we gave in the trauma bay. It was a drug we gave right before we intubated somebody to try as a sort of last-ditch effort to resuscitate them before intubation. What's shifted now is Narcan, as the sheriff pointed out, is a drug that's available in a nasal spray bottle. And I don't know if there's a more powerful symbol of meeting patients where they're at than walking into a patient room saying, I recognize where you're at. I recognize that you have an opioid use issue. I want to give you a tool, a medication that can help you. And we actually do provide that free of charge to our patients. It's through a partnership and a grant that we have that DACO helps us with. And we are able to provide every patient who comes in the ED who we think may have an underlying opioid use disorder, Narcan to go home with. If they're not ready to engage in our medical assisted therapy program, we definitely send them home with Narcan. So the story we were talking about was a pretty amazing story, actually. The patient had come in after an overdose, had been found by EMS and had been given Narcan by our Tampa Fire Rescue first responders. Came in with his girlfriend. He was essentially, after medical resuscitation, okay to go home. He was not ready to engage in a treatment program. He was not ready to engage in enrollment in our pathway. But we did give him Narcan. And first he told us, this is amazing, no one's ever treated me like this before. And he went home, and unfortunately he did relapse and he did use again. And his girlfriend actually gave him that Narcan. He came back into the ED and he enrolled into our medical assisted therapy program and got treatment through our community partner pathways. So a pretty amazing success story, I think.
And that's really what we want to hear more of. We need more of these success stories. Let's talk about surgery. After surgery, so often you hear these stories, Dr. Puri, of people getting addicted to opioids, that they're a regular person, a professional, somebody who's going to work every day, taking care of their family, and then all of a sudden they end up hooked on opioids. What other types of medications can doctors use to be able to avoid this issue?
So as an anesthesiologist practicing today at Tampa General, we're utilizing opiate-free and opiate-sparing techniques. These techniques include, sorry, can you hear me? These techniques include regional anesthesia and multimodal medication. We find our patients before they go back to the operating room, and we work with them to understand how their pain is going to occur. So before they get to the operating room, we do something called the nerve block, where we put numbing medications on the nerve cluster that comes from the surgical site and is sending signals to the brain. Because we're doing this preoperatively before the patient's actually even getting to the operating room. Once they get to the operating room, what occurs is we have to give them minimal narcotics. We sometimes even don't give them any narcotics whatsoever. This is very beneficial also post-operatively. Another thing that we do is multimodal medication, which includes other medications other than narcotics, such as ketamine, Presidex, or some sort of magnesium. These are medications that we use in collaboration with the regional anesthesia techniques to minimize the need for narcotics in the OR and for narcotics in the recovery area. These medications actually function on receptors within the brain that are different from the receptors that the opioids function on. Therefore, the combination of regional anesthesia and multimodal medication really does help with pain control while minimizing the need for narcotics. And this is a very important technique because this is a very preventative thing. So we are looking at a patient and we're preventing them from actually even getting exposure to narcotics while they're in the OR. So we're fighting the epidemic by developing less patients who have chronic pain or addiction or something of that nature. And we're treating the acute pain very carefully and in a very controlled environment. Therefore, the patient never goes into a direction where, as somebody mentioned earlier, that one dose of narcotic really did it for them. So we're trying to prevent them from even attaining that one dose, and that's the goal we have.
And is that as effective at pain management as using the opioids?
It is very effective. Currently at Tampa General, we do a lot of orthopedic surgery that we barely give patients any narcotics whatsoever. We do shoulder surgery, we do knee surgery, we do hip surgery where the patients are getting no narcotics in the operating room. They're going to the recovery area where they're getting no narcotics, and they're being discharged home on very minimal narcotics, such as 3 days. And that's really very beneficial because they're doing very well and never getting exposed to the narcotics.
That's progress. That's really impressive to hear. Dr. DeCoyne, talk to us about pre-surgery. How are you managing the pain with your patients before they end up in the OR?
Yeah, so that's great, and I think Dr. Perry talked about a fair amount of that. A certain amount of it is upfront culture change and upfront education. As physicians, it is our due diligence to let the patients know that this is what we do is major abdominal surgery. Even though we're doing it through small incisions and using the robot, and it's a cutting-edge practice, the expectation from a patient that they're going to go through this with the idea that they're going to have zero pain is not practical. Our goal is to let them know that pain is a part of surgery, and we have multiple means of treating this pain, and like Dr. Perry was saying, but our goal isn't to have no pain. Our goal isn't to completely anesthetize the patient post-operatively. So I would say educating the patient is extremely important in that capacity. We do multiple things in the preoperative workup, from what to expect afterwards, and we do give them narcotics after, just a small amount, but we even teach them, what do you do if you don't take them all? Like, you just don't leave them in your medicine cabinet, right? That leads to the story we heard.
Right.
So there's areas you can dispose of used narcotics afterwards, or unused narcotics. And then it's a culture change within ourselves that, we just don't write for 30 of Percocet and pray that the patient doesn't call us. We educate them up front, we change our own culture, and you really see a decreased need when you spend the time talking to the patients before surgery.
And we all know that change is difficult, especially when it's culture. We talked about that with law enforcement. But it's terrific to be with all of you who are on the cutting edge and who are leading that change that is so necessary. And speaking of leading edge, Dr. Mayer, you wrote some national guidelines on managing pain. Can you share with us about those guidelines and how they can apply to all different types of surgeries?
Of course. So about 5 or 6 years ago, there were some initial guidelines that were put up by the CDC and other groups that dealt with the opioid epidemic early on. And they dealt more, though, with people with chronic pain and chronic conditions. And they were kind of vague, and they basically just said, well, use less opioids. But they didn't really specifically tell people, well, what should you do? And in particular with musculoskeletal injuries, so that's some of the most common complaints people present with is injuries to their bones and joints and sprains and strains and fractures, etc. And it's not just orthopedic surgeons that deal with those, it's emergency physicians, it's primary care physicians, it's a very common ailment in society that then was getting prescribed opioids right off the bat. So what we wanted to do was we put together a group from around the country and said, well, can we help people to understand what to do with musculoskeletal injuries, whether they need surgery or not, which a lot of us do operate on these things. And then, can we give concrete examples and not just vague terms of, well, here's how you should manage patients with medication, but then also with other modalities, with physical modalities, as Dr. Puri was talking about with nerve blocks, with cryotherapy, which is doctor speak for saying ice and elevation, and with cognitive therapy, which sounds kind of weird coming from a bone doc, but talking about, guided meditation or mindfulness, which there are free apps and videos and all kinds of resources now. So we did a really comprehensive review of the literature and put out concrete guidelines on best practices for all of these different areas and systemic strategies and state databases and all these different things together. And they're all available open access. So any physician from any specialty can look these up for free online. The public can look them up for free online and understand how we're trying to come about this problem, not just with multiple drugs, but with multiple modalities, including physical and cognitive means.
And do you think we're such a fast-paced society, we all want it done right away? We're the fast food world today. Do you think that applies as well with opioids, that people just want to take the pill because it's the quick fix, but icing or elevating, going old school can actually work?
Right. I mean, we're all physicians sitting up here, but we're all patients. We're human beings, and we understand that pain, when you're hurting, you want relief instantly. And so, what I talk to my patients about is, look, I understand that you're hurting, and I want to relieve your pain, but I want to do it safely and responsibly, and we want to try to do it with multiple modalities. And because if we just go with opioid monotherapy, which unfortunately in the prior decade was the trigger, we're actually putting you at risk and putting your family and our communities at risk.
So I want to shift gears here for a moment and talk moms and babies. How big of an issue is it, Dr. Lewis, of seeing moms who are pregnant and addicted to opioids?
When you look at the fact that Hillsborough County and certainly Pinellas and Pasco has among the highest rates. When you look at the fact that they have the highest rates, among the highest rates in the state, and the fact that the opioid addiction problem does not discriminate based on age or race or ethnicity, it makes a lot of sense that you do see pregnant women, you see reproductive age women also with opioid addiction. So just based on the spread of the problem, it's not surprising that we see this problem.
Any idea why we have such high numbers here in this area, the Bay Area?
Well, that's been a struggle to basically explain, and we know that there are hot pockets around the U.S., and there are a lot of theories. Some of it may be related to the history of what people call the pill mills, right? So patients get exposed in a number of ways. Either they're overprescribed because they legitimately had surgery and we prescribed too many pills. And we do know that a certain number of people, once exposed to opioids, will develop an addiction, but they are more likely to develop the addiction if they are on higher doses for longer and if you give more pills. And we know that that was a problem for a period of time. But also, like we mentioned, after the person who was prescribed the opioids finishes, it sits in their medicine cabinet, where then other family members use it. And that exposes even more people to opioids. And so I think certainly some of the local practices contribute. The environment contributes, so that if there's more opioids in the environment, they're more likely to be exposed, again, through social circles. So there's a number of complex factors that may contribute to this being a high prevalence area.
And Dali Balakrishnan, I promised I was not going to mess up her name.
You just say Maya.
Okay, Maya. Let's talk about the babies. What's the impact on the babies when the moms are using opioids during their pregnancy?
That's a good question. So it's really not surprising, right? If there are more pregnant women that are using drugs, you're going to have more infants who are exposed to opiates. So So we've had an increase in the NIS diagnosis, and as Dr. Lewis mentioned, these increases, they're reported uniformly in community hospitals, and teaching hospitals, and academic medical centers. And it's affected all racial and ethnic groups. It's been reported nationally and internationally. And so there's a lot that we don't, while there's a lot that we don't yet understand about NAS, there is a lot that we know. So NAS is this constellation of clinical signs of drug withdrawal that occur in infants that have in utero substance exposures. And mostly it's been reported with in utero substance exposure to opiates or benzodiazepines or barbiturates. And there's a really important difference when you think about infants undergoing drug withdrawal and adults. So infants aren't psychologically addicted to a drug. They're just manifesting the clinical signs of drug withdrawal. But about half of infants who are exposed to opiates end up having clinically significant withdrawal symptoms. And about 50 to 80% of those infants will go on to need pharmacologic treatment to manage their withdrawal symptoms. These infants, they're most likely male, they're most likely lower birth weight when they're born, they're more likely to have additional diagnoses in the hospital like jaundice or feeding problems, breathing problems or infection. But that doesn't even include some of the social consequences of these babies and moms. So these infants are at a higher risk for abuse and neglect, they're at a higher risk for sudden infant death syndrome and adverse neurodevelopmental outcomes. There are some reports even that a third of these infants don't go home from the hospital with their moms. So all of these things are putting these infants at risk. And we have this great partnership with at the Substance Exposed Newborn Clinic at Mary Lee's house. And they're great. They're trying to provide additional wraparound services for these moms and infants, kind of using the nurse-family partnership model, and they're following both neurodevelopmental and social consequences for these, or outcomes for these infants up until the age of 5, because we need to learn more about what happens after they leave the hospital.
And which leads me to my next question. Do we know yet what the long-term consequences are on these children?
So there isn't a lot of literature out there about infants exposed to opiates and what happens long-term for them. But we suspect that there are problems with attention and behavior. We suspect that these infants have poor attachment with their moms. We suspect that these infants will have behavioral issues and developmental issues as they grow up. And so that's part of what our Substance Exposed Newborn Clinic is trying to assess. We're trying to add to the literature, but we're also trying to mitigate some of those effects by providing community services for these moms and infants.
And shifting back to the moms, I understand that they are at a greater risk of death if they are using opioids during their pregnancy. Can you explain why that is?
Yes. When we look at the recent data on deaths that occur within the first year after you've given birth, currently in the state of Florida, the number one cause is basically drug-related deaths, and that includes overdoses and suicides that are associated with drug use. And we think there may be a number of reasons. First, women who are pregnant can be uniquely motivated to change their behaviors, and so we do see some women who detox themselves during pregnancy, and they do so successfully for that period of time. But then you get into the postpartum period where many will lose healthcare coverage, and so you don't have any access, or at least good access, to healthcare in that postpartum period at a time when you have significant stress and a higher rate of comorbid mental health conditions such as depression and anxiety. And so we think there's a combination of factors. Some of these women are overdosing because they had decreased their use during pregnancy because they were motivated to do the right thing for their baby, and they are restarting at doses that are too high. But then also some of them are related to suicide. And so we know it's something we need to focus on to help these women.
And we know that for the lower income population that often their contact with the medical industry is the emergency department. Can you share with us, Dr. Wilson, about your medically assisted therapy pathway that you developed?
Sure. So I alluded earlier to a decade ago where we really didn't have tools to treat patients. And I think culturally we weren't quite there either. As some other speakers alluded to this also, we weren't really in a place where we understood that people with opioid addiction needed treatment. So just like we in the acute phase of medical illness, of stroke or of heart attack or of anything else, when you come to the emergency department, we need a thing to do for that patient. Whether it's something that's in our specialty or consulting a colleague, we've got to get a pathway developed for that patient so they get the right care at the right time. And so about 2 or 3 years ago now, an emergency medicine doctor at Yale published some pretty compelling data that said that initiating what's called, Mary Lynn alluded to this too, a medical assisted therapy program, or maybe try to change that language to opioid substitution therapy, or just medical treatment for opioid use. That doing that in the ER had a clear mortality benefit a year later, so less people died, less people were dead a year later. And that uses usually a medication called buprenorphine. There's a brand name called Suboxone in the ER. There are a lot of restrictions around who can use that medication in terms of prescribing, but we can give that medication in the ER. If you're going to do that, though, what that compels you to do as an emergency medicine doctor is to get outside of the ER. You have to move outside of the emergency department and develop partnerships, because you're going to give that first dose, but the medicine's only going to last 24 hours. So where does the patient go next? And I think it's actually been a pretty rewarding experience as a provider and for our patients, because it's opened me up to the community to make those partnerships and build those partnerships with Tampa General, with the DACOs and ACTs and other places that we utilize. And so we identify patients who are in opioid withdrawal. We start them on medication in the emergency department, and then we link them directly to care, and that means a warm handoff. So that means establishing a clear link to when they're going to go for their follow-up visit, usually the next day or the same day, arranging transport, having a discussion with the providers at our community resource center. It's been pretty successful in the emergency department. We've enrolled about 150 people over the last year and a half, so about 10 patients a month get into the program. And we've actually started to expand it out throughout the rest of the hospital now, so into our internal medicine colleagues, OB, and neonatology colleagues as well. And I think it's a great resource for our patients and their families in a place there was an unmet need before.
Talk about culture change. That is terrific to hear. So when we talk about changing culture, it's not just the medical profession, it is also the patients. And Dr. DeCoyne, you talked about having the dialogue with your patients beforehand and trying to create realistic expectations. What do they think when you talk to them about maybe taking less opioids, that narcotics is not the only solution? Do they seem to embrace the concept, or are they, hey, I don't want the pain?
Yeah, no, I don't think the patients have their head in the sand on this topic at all. I think they value honesty. They value taking the time to discuss it with them. I think they're very open to it, and I think the more you do talk about it with them, the more everyone becomes comfortable regarding the topic. The actual impact that's happening is more impressive. And really, these surgeries that we used to do, I mean, we would send patients home with like too much narcotics, but we thought we were doing the right thing at one point. Now, with their information changing, our techniques changing, really, they're going home with such a small amount, and they're excited about it. My partner's in the audience, Dr. Mooney, and we have a very frank conversation with them after surgery when we come back and see them in clinic. And one of the things we say is, how much narcotics did you take? And it's amazing that I would say the majority say, I didn't need anything. And, and they're proud about it. They say, I didn't need anything. I did have a little bit of pain. You told me I was gonna have some pain. I had surgery, but I didn't need any of the narcotics. And they say, oh, guess what I did? I brought them to CVS, or I brought them to the TGH pharmacy, and I disposed of my narcotics. It's just taking a little bit of extra time. You can make such an impact, but we're so rushed. I think when you just take a minute with the patient, they're receptive to it, they respond to it, and they want to do the right thing too. I mean, they're deathly afraid of becoming addicted to narcotics. So I think a lot of it is culture change. A lot of it is education. A lot of it is like slowing down your day for that one moment to have that impactful conversation, and the effect of it is real.
It can really make a difference, it sounds like. Dr. Mayor, do you find the same, that the patients are receptive to this change and this change in expectation of how to cope with the pain?
Yeah, absolutely, we found that. And that was part of our culture change with our patients and our practice, that we started with our Tampa General protocol and now is being adopted in orthopedic practices across the country, was that at discharge we still prescribe opioids. I mean, the surgery that we do and the injuries that we treat hurt, but along those lines we also now prescribe over-the-counter medications, where before we used to just tell patients to take anti-inflammatories or Tylenol or acetaminophen or even a nerve pill. Now we prescribe those medications. So whereas 4 or 5 years ago, I'd say every refill call that our office received was for another opioid, I'd say now I rarely get a refill call for an opioid, but it's a refill call for their prescription-strength anti-inflammatory. So it's totally flipped our practice around in that we can't assume that the refill request is for an opioid anymore.
That's encouraging to hear. Now, I'm sure there's some cases where you can't get away from using opioids and dealing with specific procedures like removing a kidney or a lung transplant. Are there other processes that are working for you, other medications that are working?
Thanks for the question. Again, we're utilizing nerve blocks in lung transplant patients as well, and this is I'm very passionate about this. Our lung transplant patients unfortunately can't get a nerve block before they go into the operating room, secondary to a possibility that they may have to be placed on a cardiopulmonary bypass. However, they can still get multimodal medication during the operation. Once they have had their lungs transplanted, we put a nerve block in post-operatively, almost immediately, maybe 5-6 hours after they come out of the ICU. The lung transplant patients usually get something referred to as an epidural. It is a type of a nerve block. Most people know it as something you get when you're in labor. And the concept of this epidural is that we're blocking the nerve signals that come from the chest wall. So the patients, this is preventing the patients from having significant pain. They require less narcotics. They also in turn are able to take deep breaths. And actually, the placement of the nerve block actually sets on a cascade of events that follow, which includes earlier moving of the breathing tube or extubation, decreased need for re-intubating the patient, decreased delirium in the ICU, also improved rehabilitation and right away. Actually, we get these patients, incredible, we get these patients who've had bilateral lung transplant up almost 10 hours or 8 hours after the operation with minimal or no narcotics. And that in turn helps with discharge home. We worked with Dr. Patel, who's our lung transplant ICU physician at USF, to decrease the length of stay that patients have in the ICU by almost 4 or 5 days, and the length of stay in the hospital by a significant bit more. And what that does is that joined together helps with decreasing the morbidity and mortality that these patients have when they're getting these lung transplants or bilateral or single lateral or even kidney transplants. And most importantly, it helps with making sure that the organ that is being transplanted is working and working very well before the patients go home.
Well, you have me convinced if I need my kidney removed, I'm coming to you.
Absolutely.
Okay, it's time now for our lightning rod, and I want to pose a question to all the panelists, and if we could start with you, Dr. Wilson. The question is, what are the medical benefits to reducing the use of opioids?
So there are quite a few. I mean, first of all, opioid use is related to increased mortality, right? So there's that piece. But also, a lot of the things we, like Dr. Murr alluded to, had used opioids for in the past really didn't have much evidence behind them. Unfortunately, went through a phase, I think, where big industry or whatever the mechanisms were that led us there, opioid use by physicians had increased and opioid use for different conditions had increased quite a bit. So we were in kind of a place where we're using opioids for really not a good reason medically. And so that, you heard some from the other panel members here, that put our patients at risk for a number of things. If they had other disease states, they had worse outcomes with those disease states. And then one of the things I work on quite a bit is the opioid use itself. Most of our patients will eventually end up using intravenous drugs. If they're using opioid drugs, they'll start to abuse intravenous drugs. And when you abuse intravenous drugs, I always tell our patients, either you have hepatitis C right now, or you're gonna have hepatitis C in the future. So co-locating those epidemics and treating them both is really important as well.
And Dr. Muir?
So I think that, obviously we know all the negative health effects of opioids, and the death is what gets all the headlines, right? Because that's the ultimate worst outcome. But there's all these other associated illnesses that are made worse with opioids. Really, if you look across the literature, there's no condition that it has improved outcomes with opioids in any specialty. So I think that if you want improved outcomes from any illness that you have, to minimize opioids is going to lead you down that pathway of having a better outcome and having better health.
And Dr. Balakrishnan?
From a baby perspective, because I'm a baby doctor, I think that literature shows that opioid exposure in utero to an infant's developing brain is probably not great. And postnatal exposure is also not great, and we don't really know what kinds of neurodevelopmental outcomes that can lead to. And so a lot of neonatologists are trying to use quality improvement approaches to standardize care and enhance non-pharmacologic approaches to manage withdrawal signs in babies and decrease opioid exposure. So that would be my take on it.
We'll take it. Dr. Lewis?
Well, certainly we know that the cesarean section is the most common surgical procedure performed nationwide. About 1% of people who have opioids after a C-section will become addicted. So from that perspective, we know that by substantially reducing opioid use after a cesarean, we can make a big difference in the women who are being affected by misuse and addiction afterwards.
1% too many, right? Dr. DeCoyne?
Yeah, so as an elective GI surgeon, my goal is to take someone who's fairly healthy and make them healthier through surgery and get them through the hospital essentially as efficiently as possible. Opioids slow GI motility down, they lead to constipation, they lead to decreased respiratory rates, poor motility after surgery. So by eliminating just in that facet opioid use, we get patients healthier quicker and we get them home safer to their families. So.
And last but not least, Dr. Puri.
I would just echo what my colleagues have already stated. Opioids have their own side effects, which include cardiac depression, respiratory depression. They can lead to delirium. They can lead to sedation, especially in elderly or in young children. They can also lead to constipation, nausea, and vomiting, as Dr. DeCoyne mentioned here. If we can decrease that, we can decrease the use of opioids, we can decrease all those other complications from occurring, and subsequently any other complications that may occur from the cardiac depression or the respiratory depression and down the line.
It's really impressive to hear the progress that you all are making, and it's really an honor and a privilege to be here with the people who are on the front line of trying to change the culture and make a difference and combat our opioid crisis. So thank you. I know you all have very busy schedules, so thank you so much for taking the time to be part of this. And at this point, I want to welcome back Dr. Laura Hobner for a final word.
Well, I have the easy part here. First, I want to thank Laura McElroy for moderating both of these panels. I think she did a wonderful job, and we really appreciate her taking the time to do so. And of course, I want to thank all my wonderful colleagues here for not just coming out tonight, but for their great contributions as well to Tampa General Hospital and to healthcare. Thank you all. Last, I'd like to thank all of you in the audience. Thank you for coming out tonight, and I hope you all have learned something. Of course, special thanks to Candace for sharing her story, and thanks to all of the community panelists as well for their participation. I think we got a great vision of all that's being done in our community. You know, Tampa General has a vision to be the safest academic health system in America, and with all of our help, we can achieve that vision together for the community. Thank you all. Please drive home safe and have a great night.